The title of our poster is Integrating Pharmacist-Guided Pharmacogenetic Testing into a Medical Residency Clinic. This poster was submitted as a developing project poster. Roughly 3/4 of the testing of a target population of 100 patients to undergo pharmacogenetic evaluation was complete at the time the poster was prepared. Unfortunately, the study was suspended early due to the pandemic, and thus the total population to be tested is now 92 patients. This study formed a collaboration between an academic institution, the University of Minnesota College of Pharmacy, and a family medicine residency clinic, the Duluth Family Medicine Residency Program. The long-term goal was to improve medication safety and effectiveness by incorporating pharmacogenetic testing and expert pharmacist consultation within a medical residency clinic. Short-term objectives included engaging key stakeholders, identifying a population of interest, ascertaining a pharmacogenetic testing platform, creating service workflow, and lastly, developing curriculum to educate medical residents and faculty on the use and application of pharmacogenetics. Moving to the methods section. We knew it would be important to engage stakeholders. Stakeholder engagement is critical for the implementation of new clinical service. Ultimately, stakeholders were identified and included medical faculty and residents, pharmacists within the residency clinic, as well as pharmacists from the University of Minnesota College of Pharmacy with expertise in the area of pharmacogenetics. Establishing an expert consult. In development of workflow, it was determined that a subgroup would be formed to analyze each patient's test results. This group consisted of the clinic pharmacists, pharmacogenetic focused pharmacists from the College of Pharmacy, as well as a pharmacy fellow and a pharmacy resident. The group met every other week to review cases, interpret results, and develop recommendations for medication adjustments if needed. Identifying drug-gene pairs. To help determine which patients may benefit from pharmacogenetic testing, the group did the following. First, we evaluated clinic prescription volumes for the previous 12-month period at the residency clinic, and then compared that data with the Clinical Pharmacogenetics Implementation Consortium, or CPIC guidelines. This helped to determine which high-volume medications being prescribed at the residency had available pharmacogenetic data. We found the most commonly prescribed medications with pharmacogenetic guidance were those used for treating anxiety and depression, such as SSRIs and TCAs. Ultimately, the population that was studied was primarily patients with anxiety and/or depression. Based on this information, eligibility criteria were developed. We did work to allow for broad eligibility criteria. Patients are eligible for enrollment if they currently or may be prescribed a medication with pharmacogenetic guidelines and have not previously undergone pharmacogenetic testing. Selection of a pharmacogenetic testing vendor. There were no in-house testing capabilities, so we needed to work with a commercial vendor. We were able to procure grant funding to cover the costs of the test and decided to work with the Minneapolis, Minnesota-based vendor, OneOme. OneOme is able to provide a 27-gene panel of 70 variants related to medication safety and efficacy. Moving on to education. Faculty and resident education will be performed annually. This education was co-designed and delivered by clinic pharmacists, pharmacogenetic pharmacists from the College of Pharmacy, as well as physician residents. We found the education was most impactful when background pharmacogenetic information was coupled with cases. The cases were presented by the medical residents, and interpretation of results and rationale for medication recommendations were reviewed by the pharmacists with pharmacogenetic expertise as well as the clinic pharmacists. Establishing infrastructure. Because the testing was done via a commercial lab and there were no direct communication of results to the health system EHR, several items needed to be developed, and these included developing an initial and follow-up visit documentation template, adding an allergy and tolerance alert for secondary findings. An example of this would be a patient identified to possess a variant that would impact a drug therapy that they're not currently using, but could be prescribed in the future. An example would be increased risk of carbamazepine-induced hypersensitivity associated with the HLA-A star 3101 allele. A problem list diagnosis code was added for each patient tested. Pharmacogenetic testing completed was added with a diagnosis code of encounter for pharmacogenetic testing, which utilized the ICD-10 code of Z13.79. Commercial vendor results and expert panel consult notes scanned into the EHR were labeled under pharmacogenetic test results. And then to demonstrate value, we did collect data on recommendation acceptance, as well as clinical scores such as PHQ-9 and GAD-7 pre and post intervention. And lastly, a provider survey was completed by our pharmacy resident, which established an understanding for a level of provider comfort with pharmacogenetic testing and satisfaction with the service provided. Moving on to the results section. With respect to demographic analysis of the first 75 patients, 53% were female with an average age of 38 years. 96% identified as white. Half of the cohort was on either a state or federally funded insurance program. A majority, or 71% of the cohort, had both depression and anxiety, whereas a smaller portion, 9%, had anxiety alone, and 20% were noted to have depression alone. A majority of results, 72%, were delivered to patients in clinic, whereas a smaller portion were communicated via telephone or mail, and a small number of patients were lost to follow-up. With regard to phenotype distribution, the two more commonly actionable phenotypes of CYP2D6 and CYP2C19 at 57% and 46% of patients demonstrated normal metabolism, respectively. The other half of the patients demonstrated either ultra-rapid, rapid, intermediate, or poor metabolism, which could influence both their response and tolerability of the medications. Regardless of phenotype, even when normal, our patients anecdotally found the value in the testing with respect to it either corroborating their experience or providing them with more confidence to adhere to their personally suited regimen. 76 clinical actions were implemented based on 87 clinical recommendations. The reason for fewer clinical actions versus recommendations was due to there being more than one recommendation per patient case. We can see in the bar graph that either no change or starting a new medication was most commonly recommended. Please note, these recommendations take into account both the pharmacogenetic results as well as a patient's personal experience and preference. In addition, from the graph, we can see that clinical action that was implemented largely followed with the suggested clinical recommendations. In conclusion, key stakeholders included a multidisciplinary group of experts, pharmacists, and physicians. When in-house testing is not feasible, an external pharmacogenetic vendor is appropriate to use. Recurring education is key for sustainable implementation into clinical workflow. Pharmacist recommendations were vastly accepted by physician residents. And lastly, implementation of a pharmacist-led pharmacogenetic evaluation into clinical workflow was feasible and accepted by medical residents. Thank you.